Okay, think about this for a second. Your body's vascular system, all your arteries and veins, it's basically a massive network of superhighways, right? It's constantly moving traffic, keeping everything running perfectly. It's an incredible piece of engineering. But what happens when that system gets attacked from the inside? Well, that's the big, scary question we're tackling today. We're diving into this really high-stakes battle where surgeons have to fight a tumor that's growing inside the very blood vessels that keep us alive. So here's our roadmap for navigating this whole medical gauntlet. First, we're going to identify these hidden tumors. Then, we'll look at how doctors actually unmask them. After that, we'll get into the absolutely wild surgical feats needed to get them out. We'll do a special deep dive on what it takes to replace the body's biggest vein. And finally, we'll take a hard look at the fight for survival. All right, first things first, we need to understand the invader. And these tumors, well, they're not your typical cancer. They are stealthy, they are dangerous, and they are incredibly rare. So right off the bat, you got to know there are two main ways this whole invasion happens. You've got primary tumors, which are the rarest of the rare. They actually start growing from the wall of the blood vessel. But what's more common are secondary tumors. They start in an organ nearby, like the kidney, and then they grow into the vessel. It's like an aggressive weed breaking through the pavement of a highway. So who are the main players here? Well, there's aortic sarcoma, a primary cancer of the aorta, the body's main artery, and it's super aggressive. Then there's venous leiomyosarcoma, the most common primary tumor you'll find in veins. But the one that surgeons often run into is renal cell carcinoma. This is a kidney cancer that can do something really nasty. It can grow what's called a tumor thrombus, which is pretty much a solid finger of cancer that snakes its way right into the body's main vein, the IVC. And the scariest part? The absolute stealth of these things. Get this. A study from 2014 looked at 26 cases of aortic sarcoma and found that in every single case, not once did doctors initially suspect what was really going on just based on symptoms. That just shows you what a challenge this is. Which, of course, brings us to our next chapter. How in the world do you find an enemy that's so good at hiding? Well, it takes some serious medical detective work. A huge part of the problem is that the clues are just so vague. Patients might feel a general sense of being unwell, tired, maybe they lose some weight without trying, or they have a bit of belly pain. These are symptoms that could be 100 different things, which is why these tumors can hide in plain sight for so long. And that's the key takeaway here. You just can't rely on symptoms. Doctors have to literally look inside the body. Advanced imaging like CT scans and MRIs are absolutely essential. They become the eyes that let surgeons see the tumor, find its exact location, and really understand how it's tangled up with those superhighways. And let me be clear, tackling one of these is never a one-person job. It takes a whole crew, what's called a multidisciplinary team. It's like assembling the Avengers of surgery. You'll have vascular surgeons, cancer surgeons, urologists, even heart surgeons, all huddled together, planning the attack. This kind of collaboration is just fundamental to modern cancer care. And they've got some seriously cool tech to help them. Things like 3D modeling are a total game changer. It basically creates a digital twin of the patient's anatomy, mapping out the tumor and everything around it. It's almost like a flight simulator for surgeons, letting them practice and plan every single move before they even make an incision. Okay, now for the main event. The tumor's been found, the team's assembled, the plan is locked in. Now, surgeons have to step up and perform some of the most complex, most high-stakes operations you can possibly imagine. You can think of the operation in 4 key steps. 1, get in there, make the right incision to see everything. 2, expose and get total control of the blood vessel. 3, cut out the tumor en bloc. That's a fancy term for taking it out all in one piece, with the section of vessel it's stuck to, making sure no cancer cells get left behind. And 4, the most critical part, rebuild that superhighway so traffic can start flowing again. So how do they rebuild it? Well, there are 2 main choices. If they only had to remove a small piece of the vessel wall, they can do a patch closure. It's kind of like patching a tire, often using a special material made from a cow's heart tissue. But if a whole section of the highway is gone, they have to do a full graft replacement, putting in a high-tech synthetic tube to bridge that gap. Now, to really wrap your head around the scale of this, let's zoom in on the most dramatic example there is, replacing the single largest vein in the entire human body. Meet the inferior vena cava, the IVC. This thing is a massive vessel. It is the main pipeline that brings all the used blood from the lower half of your body all the way back up to your heart. So yeah, when cancer decides to invade this thing, the stakes just couldn't be any higher. And check this out. This part is just so cool. To make sure that patch repair is absolutely perfect, surgeons use some pretty elegant math. There's this precise formula that tells them exactly how wide the patch needs to be, all based on the vein's size and how much of it they took out. This is crucial because it stops the vein from getting too narrow, which would be like shutting down a lane on that superhighway. It's just a perfect mix of medicine and mathematics. And when they need to replace a whole segment, this is usually the tool for the job, an ePTFE graft. It's this durable synthetic tube, but the really clever part is those external support rings. They act like the supports inside a tunnel, keeping the graft from getting squished flat by all the other organs crowded inside your abdomen. So, does it actually work? Oh yeah, it works. The 10-year patency rate, which basically means the graft is still wide open and working perfectly a decade later, is at least 88%. That one number just speaks volumes about how successful these massive reconstructions really are. But after all of that, after these incredible surgical procedures, what are the results? This brings us to the most important question of all. What does that fight for survival actually look like for these patients? The outcomes tell a really powerful story, and they show just how different these cancers behave. For that super aggressive aortic sarcoma, the one that starts in the main artery, the 5-year survival rate is a heartbreaking 3.5%. But now look at the difference when the cancer starts somewhere else and grows into a vein. For tumors cut out of the IVC, that number skyrockets to 52%. And for that kidney cancer, the RCC, if it hasn't spread, survival's around 60%. It just goes to show you where the cancer starts makes all the difference in the world. In fact, the absolute biggest win is seen when surgeons go after that renal cell carcinoma aggressively. For patients where the cancer hasn't spread, this kind of radical surgery can push the 5-year survival rate all the way up to 71%. It's proof that even with all the risks, these heroic operations are absolutely saving lives. But we have to end this on a realistic note. A key takeaway from the experts is that while surgery is an incredible tool, it's not the final answer. To really push survival rates even higher, surgery needs backup. We desperately need more effective adjuvant therapies, things like chemo or radiation, that can fight alongside the surgery. And that really leaves us with this final big picture question. We've seen surgeons do things that seem almost impossible, literally rebuilding the body's superhighways. As they keep pushing the limits of what they can do in the operating room, the next great frontier is figuring out what new therapies are going to join them in the fight against these rare but incredibly deadly cancers.